like to welcome everybody and thank Dr. Virkus for joining us today. I want to ask what prompted the study, that is, what made you and your partners want to change from the traditional practice of staging most all bicondylar tibial plateaus.
Sure, thank you. As I think most of the viewers would know, this is a long history, and I think you can group tibial plateau and tibial pylon into the same mix here, even though this paper was purely on plateaus. But as everybody knows, the early experience with acute fixation of both those injuries had a high complication rate, high infection rate, wound healing problems, etc. So Mike Shirkin's paper was the first to talk about it with pylons on a staged approach with XFix followed by ORF, and then Ken Eagle subsequently did a very similar paper on tibial plateaus, and that pretty much led to what most would probably consider the standard of care of a staged approach in both of these. And to get very to the answer of your question, I think we felt that we would see plenty of patients who we'd be taking to surgery for the staged approach, and we would look at them and look at their leg, and none of the reasons for doing the staged approach were present. For whatever reason, they weren't very swollen, or they had just moderate swelling and no blisters. And we'd be sitting there kind of scratching our heads of, well, why don't we just go ahead and fix it? And then get into these conversations like, oh, well, if you fix it right away, terrible things are going to happen. And so I think the summary is that, the pendulum maybe swung too far to the staged approach, and it became just the default answer for quote unquote every plateau or every pylon without kind of taking a more individualized approach. And then, we certainly had seen literature from the Vancouver group on the acute fixation of pylon fractures. We started being a little bit more aggressive, and that is actually what led to this paper.
So how have the results continued to change your practices? That is now 2 years after the study was published. Is that still the same, or is it swung even more towards the acute fixation?
I think it's swung a little bit more. I think it opened the eyes of some of our team. We had during that study period, and still now, we have a team that kind of varies from fairly young practitioners who have only been in practice a few years to a number of more seasoned attendings who have been in practice 20 years plus. And so that was a lot of the selection bias of who got what during that study period. The younger guys were very nervous about taking any chances, if you will, if you want to word it like that's probably not very well worded, with acute fixation because of, what to some extent is the dogma of, quote unquote, everything should be staged. And so I think as more of our team saw the results of acute fixation, we talked about these repeatedly in our daily conferences. We've noticed both on plateaus and pylons that when you do them early, it's certainly way easier. I don't think anybody would argue with that. But we were also really surprised at how many times that almost never did the swelling get worse, or do we really have the wound problems closing that we might have worried about going in. So I think as more of the team saw that, they became a little bit more open to the staged fixation. We've always been a team that's been fairly focused on cost control, and certainly, the cost differences in the 1 versus 2 stage are really quite dramatic, but they can't ever outweigh what's best for the patient or patient safety issues. So it's trying to find that balance. And then, certainly the complicating factor in all this is we don't really have anything objective at all to tell us when it is clearly safe to do it in one stage. It's very subjective with wrinkle tests, squeeze tests, blisters, etc. So I think that's what many times makes practitioners uncomfortable, is there's no real clear sign of when it's okay to proceed in one stage. But I would say we're as aggressive, or at least as aggressive as we were during the study time. And to be honest with you, the times that we do a staged approach, it's typically either because there's very clear soft tissue injury that's not amenable to early surgery in the surgeon's opinion, or to be honest with you, many times it's just more of a time approach. So it's a case that you might do acutely, but there's 4 or 5 other things on the schedule that day, and you just don't have the 3 hours or so to be doing the acute OR for the plateau, so it gets staged so it can be put on an elective schedule.
Any particular pearls? You kind of alluded to some of the things you were looking at for the viewership. A young practice is looking to do more cost-effective and efficient patient care.
So, it's a spectrum, and I think a lot of it comes down to your own experience. But certainly the things that allow you to, I think, comfortably go forward acutely is the same criteria that you would use when it's safe to go forward if you're doing it staged. So I think wrinkle sign is something that would make people comfortable. Again, it's the palpation of the leg and the compliance of the skin compared to their other side, and whether that skin is under tension, whether it's shiny, whether it has wrinkles or not, is typically, I think, the things that people will go by. For most people, if there's any blistering, that would be a sign to not proceed. I can tell you there are cases of plateaus and pylons that if there is a very small amount of serous blistering and it's away from where my incision is going to be, I have done acute fixation without regretting it. But that's probably something that you would want to only do if you really had a lot of experience treating these issues. I think blistering would probably be should be a hard stop for most people that don't do these cases in a significant volume.
If you were to repeat a similar study or design a new study, what would you do differently?
Yeah, that's a good question, and we thought about that. The biggest barrier to doing a better study in this, I think, is the lack of objective criteria for stratification of the soft tissue. Even the soft tissue grading systems we have do not really help you at the low end of the injury soft tissue spectrum, determining whether it's safe or not. I think that one of the comments that came from some of the reviewers is, we did stratify based on AO classification, and obviously had C3 injuries, but the bottom line is there's a lot of difference between C3 injuries. There's even a lot of difference between C33 injuries, and so that's where it becomes more difficult. So I realize I'm not really answering your question. Certainly any prospective study is going to be better, and you could probably make a list of soft tissue criteria, so blisters, wrinkles, some of those things, and then follow things prospectively would probably be the best way to improve the study. The problem is, and we've actually talked about this, for example, to do a prospective study on this in the pylon, which I think is, again, a very, very similar injury and very similar considerations. When we looked at setting up a prospective study, looking at really deep infection as the main variable, it was going to take. It's been a while since I did this, but something like 400 cases to be. I can't remember if that was 400 to be randomized or 400 per group, because when I saw the 400 number, I knew that was going to be pretty close to dead on arrival. Because not that you couldn't get 400 pylons, but it would be very difficult to convince trauma surgeons to randomize this group to ORIF. I just don't think people would buy into that. I think the people that have done it and have experience of it would have no problem, but there's still a very large contingent that would make them very nervous, and I understand that. There's a lot that plays into this. The potential outcomes of making the wrong decision can be devastating, and so I understand that, and it certainly is. It is the safer decision to do it staged because that's what everybody else does, and that's what the literature supports. But my personal opinion, based on my experiences, I actually think the complication rate is probably higher in 2 stages if you carefully select your 1 stages, all comers. But that is going to be very difficult to ever prove in a prospective study.
Do you have any other parting comments that we didn't hit on specifically?
We would hope that this paper would challenge people to kind of just be more thoughtful of an individualized approach for patients. I don't know if it's been published yet, but I know Dan Horowitz and his group had a very similar study, but it was older. It was only in the elderly patients. And they found the exact same thing, that the vast majority of these, even bad injuries in elderly patients, could be treated acutely. Now, the energy in many of those patients, even though the x-ray looks the same because of the bone quality, the energy imparted to the soft tissues is lower. So that'll make a lot of intuitive sense to many people. But I think the gist of it is that, make an individual decision based on your patient, what's going on with that particular patient, as opposed to seeing the x-ray and seeing it be a bicondylar and just defaulting that automatically that needs to be X-fixed for a stage approach. But again, there certainly are many people that need to be X-fixed with a staged approach.
Of course.